Okay, so welcome back everybody. We'll start the final session, which is on the quite applied topic of healthcare, and three really good papers that seem to connect quite well from a general perspective down to more specific issues, as you'll hear as we go along. And so our first speaker this time is Professor Eamon O'Shea, and he will look at the topic of health productions. Now I know just before we begin the paper, Eamon can't stay for the whole session, so we'll have questions directly after each paper.
Thank you. Okay, so I'm going to look at some policy issues with respect to health production, and just think about the debate about health and healthcare in the context of prioritisation of where we should be putting scarce resources or ever scarce resources. Some of the things that come up, in the discussion you see on the screen. It's very rarely we talk about health production, however. We really talk more about healthcare and hospitals, about illness. So we tend to sort of frame the debate very quickly into one of buildings and medical people and nurses and so on very quickly. And that's one of the things I want to get to at the end of the discussion. And increasingly then we talk about healthcare in terms of efficiency and effectiveness, and in third place usually comes equity. Normally we think about, can we be more efficient, can a healthcare system be more effective? We're looking for clinically based results, we're looking at evidence-based medicine, we're looking for things that work. But all the time in healthcare, when there is criticism also, there is criticism of bureaucracy, and we, particularly recently or in the last 4 or 5 years, the growth of the HSE, we tended to focus our critique on never expanding bureaucracy and never shrinking sort of provider mechanism for healthcare. We began reform proposals. Heading towards universality, so the Dutch model of insurance for the Irish healthcare system. But all the time we sort of think about priority setting, about how we think about priority setting. I said to you there when I came in, I'm on the All-Ireland Institute for Palliative Care and Life Care, and all my work at home is on dementia. And one thing is that when you're engaged with sort of vulnerable groups, particularly vulnerable groups like people with dementia, you realise that you're way down the pecking order with respect to priorities. And when you think about prioritisation in healthcare, some people are more worthy than others when it comes to healthcare. That's not for today's debate, but it's an interesting debate about who gets treated, who dies. Say a little bit about the who dies business today. There are some of the issues. We know that the sort of demographic imperatives, things are going to get a lot more interesting here. And the reason it's going to get a lot more interesting is because there'll be more of us, meaning older people. And one of the things with older people is they tend to get sick a bit more, and they tend to call on more resources in terms of healthcare. Some of those figures, number 85 will quadruple. Of course, these are successes as well. The fact that we're living longer is a huge success. We see soon in while life expectancy. But certainly aging is going to create interesting difficulties in terms of prioritisation and resource allocation and public and the whole issue of who gets treated and for whom. These are just some of the background stuff. Some of you know this and some of you don't. But it's on the slide anyway, which presumably you get. So we tend to spend about average, just simply below average GDP on healthcare. In terms of gross national income, we're about the 7th highest of 27 OECD countries. We did tend to increase our spending in healthcare quite dramatically in the last 10 years, from 6 billion to 15 billion. That's a lot of money going into spending on healthcare. And of course the question is raised immediately. I'm an economist by training, although I probably wouldn't get into the union now because I've been doing sort of economics, except to do health technology assessment. Economists worry a little bit about, if your spending goes up from 7 billion to 15 billion, doubles, the immediate question is, in a really crude way, well, has health gone twice, has health increased by 2? Has debt halved by 2? It's an interesting question. We have also spent increasingly on primary community care in recent years. I'm not going to go through that table, except, I suppose the one thing to notice all the time is when spending, and look at the bottom of the USA is spending about 16% of resources of GNP, which is roughly twice as much as the UK, roughly twice as much as the OECD average. Again, the question is, so next time you go to the US, try to figure out that they're twice as healthy. These are crude economics. Nevertheless, it's sort of interesting questions about who gets what, and so on. Per capita expenditure, you can see the same thing. Ireland about just under 4,000 purchasing power spending, US 7,000 or 8,000. So we remain in the middle, you know, remain just sort of around the OECD averages. I'm not going to say much about entitlement. You can see, you know, Ireland is a complicated system. I mean, if you ever tried to figure out the Irish healthcare system, I mean, I remember I was doing research in the next for a long time on ageing, and I had to try to figure out my own mother's care who got Alzheimer's disease. And I was used to go home with this illusion saying, I write about this stuff, surely I can organise a public health nurse to call. But not always the case. It's really complicated, and complicated by the fragmentation, by entitlement issues, and essentially information issues. There's a huge information deficiency at the heart of Irish health and social care. It's a classic economic asymmetry of information. People simply don't know. There's not enough of people in primary and community care, and what's out there, we simply don't have the mechanism to get people who need to people who can deliver. It's a really interesting and simple problem, actually, but we don't seem to be able to resolve it. It doesn't always take a lot of money in terms of coordination of care and integration of care, and I see a paper following on the integration of primary care, and it's really interesting that how much we can do without spending a lot of money. Classic information problem, you know, Ireland is in one sort of basket case with respect to complexity, with respect to healthcare, and entitlement, which is hurting people, actually. You know, it's causing the stress, where it didn't cause the stress. So, funding, we're a mix of public and private funding, mainly public, you know, public resources, but of course, you know, a significant number of us, you know, giant private insurance companies, used to be VHI had a monopoly, and now there's competitive private insurance, but a lot of people join private insurance, and we'll see this is one of the points in the paper later on. We have a community-rated insurance system that's under pressure because, you know, community-rated system, good risks tend to subsidise bad risks, i.e. younger people tend to subsidise older people, and that's unlikely to remain. So we're looking at, unless we move towards the universality of the social insurance system, we're likely to be able to hold the line here on community-based social insurance system. The governance issue is a really interesting issue. You know, we didn't like the health board, so we got rid of them. We've substituted with the HSE. We don't like the HSE either. So now we've gone back to something else that I'm not exactly quite sure of, and nobody is yet. All we know is there's seems to be a lot of management going on. And we're not quite sure how effective that is in terms of impacting on outcomes. So these are some of the background. I guess what I want to get to the nub of this, I know I've only 20 minutes, and we're wasted 7 of our introduction. But one of the things I guess is I want to show, first of all, that things aren't all weak. You know, we've had significant gains here. We've had significant life expectancy gains, for example. You know, at birth increases and at 65 years of age increases. You know, in the 20 years between 91 and 2008, you know, at 65, you know, if at age 65 you can expect another 3.4 years for females and 3.7 years for males. You know, which is a significant increase in the number of years. You know, this is something to be celebrated. You know, we tend to denigrate our health system really quickly for good reason, as we'll see. But at the same time, I think there's been significant gains. The question you should be asking in your head right now is, of course, is this anything to do with healthcare at all? And that's where I guess the infant mortality rate has as well. Really significant gains. You know, and we have had age standards, death rates fell by 26%. This is a cause for celebration. Mortality diseases from heart and heart disease down by 54%. We've been less good on cancer. It's been less good on cancer. We're still lagging behind, but improving. When people ask us about their health, that is something that you guys probably know much more about me, being an economist who tends to think things very narrow-minded things. One of the things about culture, people ask you, how's your health? We in Ireland tend to give an answer with grand anyway, so it's probably not wise to be comparing us to, you know, Scandinavia on this, where you get actually truthful answers to questions about how you're feeling. But you know, when something like the European Health Consumer Index, Ireland's ranked 13 or 31 countries, One of the things that we're constantly getting the message that our health system is awful. It's just useful to remember that there are some good things. Similarly with consumer satisfaction, and the paradox therefore is this: we've got increased life expectancy, we've got better health. We say we're okay generally when people ask us for subjective health. The thing is, we tend to get high satisfaction from users. If you get into our system, or if I don't know whether you're public or private, but I know quite a lot about the public system. And once you get into the public system, it's actually pretty good. It's actually getting in there is a problem, and this is a big issue. But you can see where, just took the Sunday Independent on the 6th of June, worried about banks just wait for the health crisis. So we've been in constant crisis with respect to health, but actually we haven't. We've been in constant crisis with respect to healthcare. It's a very different thing. If we were in constant crisis with respect to health, some of the problems we have now would have arisen. And this is the sort of point I want to make that's central to what I'm trying to get at here in this paper. So one of the things that comes up a lot is access to healthcare, and this is a key driving force to sort of thinking about the reform of the Irish healthcare system. We know we have duality of access. We know that those of us who joined the private health insurance, even those of us who are committed to egalitarian universality, joined the public insurance system because we know that it guarantees us access to healthcare quicker than if we weren't in the VHI, and make sure that some of the access problems that we've had if we were public patients wouldn't occur. The incentives are perverse. Consultants are encouraged in the private system to treat private patients and leave public patients to less experienced colleagues. Hospitals are, the perverse incentive is to take private patients, and there are longer waiting lists. We know the scandals of people waiting for beds and dying and so on, which are quite distressing. Accidents, emergency waiting times. I heard coming up in the car this morning, today, if anybody's interested, there's 363 people on trolleys today, if anybody's interested. So we know these. We know that these exist. We also know, and I'm not going to steal the thunder of the latest video. We know there are weak primary community care, and this is an area where I work in a lot. The weakness of community care for people, older people, people with disabilities, people with dementia. Community care is, for all the good work that's done by people who actually work in community care, and significantly good work done by people in, there's simply not enough of it. So what tends to happen is caring tends to be done by families, and caring tends to be done by voluntary groups all the time for chronic diseases like dementia. Much of the care is done outside the formal state system. So what have we done to address deficiencies? Well, we've done. The new government have said they're going to reform the healthcare system. The last government tried to solve the problem by privatising more. I guess I'm quite unsure that I was ever going to work, but they did try it. The new government says that we're going to go to universal health insurance, even though we're not sure. Even though nobody knows quite sure how that's going to work and what it's going to cost. We were heading in that direction. Single-tier healthcare system. Primarily, this will serve to reduce unequal access to healthcare. So we're trying to get away from the sort of duality of care. Free GP care for all citizens, emphasis on primary care, emphasis on care at the early stages, health promotion, health outside health technologies. Accelerated development of primary care teams, special delivery units to eliminate waiting lists, and so on. That's the game in town. That slide is the roadmap to where we're going. Yeah. Primary view in this paper is that it's not going to make that much difference. And the health production. And some of you may know already, but it's useful to document this. And these are necessary conditions. I'm not saying it's good. I'm not saying it's not good. In fact, it's something to want as I would want. I'm not saying equalising access is not a good thing. Equalising access to a fundamental health is absolutely primary in my view. But it's only a necessary condition. It's not a sufficient condition. We need to think about equality of health outcomes, equality of health opportunities, and one of the issues is a really poor understanding of the production. production of health, which is what this paper is about. Because we think about health production as in health production means I keep doing, you know, I'm born, I'm disadvantaged, I engage in bad behaviours, I end up in hospital, and then health production happens. You know, I'm repaired, I'm sent back out again, I come back again, I die. I think we need to have a different view of health and health production that maybe thinks a bit about life course and about the sort of life cycle reproduction of poor health. And also, interestingly, in the last paper I was interested in, I think one of the things that I'm doing a lot on dementia at the minute is looking at how communities can be mobilised to respond to the problems, the issue of dementia. I think communities, sort of, okay, starting with families, communities can play a big part in production of health, both physical health, mental health, cognitive and so on. I also think that maybe we need to think about a little bit more about linking the economy to and thinking about health and its impact on the economy, production of health linking to sort of more broader economy. It's a useful strategic way anyway of thinking of a larger role for health, but particularly with respect to mental illness. We did a lot of work on a couple of years back on the economics of mental health. And the economics of mental health is primarily about keeping people at work, making sure that work allows people to stay at work and allows people with mental illness sort of to engage in meaningful connectivity. So all of that I think is important. The big issue for me is just looking at differential life expectancy. We know these exist. You know, there's differentials in standardized death rates for professionals as distinct from unskilled manual workers. There's differential by housing tenure, by education, there's area deprivation. All of these we know. Now we didn't know them for quite a bit. You know, Brian Mullen did a paper in 1990, and I did a couple of papers in the 1990s and 97 looking at some of these issues. You know, we tended not to, and now the All-Ireland Institute of Public Health have sort of did some work in the early 2000s and so on, looking at inequalities. Unlike in Britain, sort of the Black Report and so on, much earlier began to sort of look at a social class of health. There wasn't that much tradition here in Ireland looking at the mortality differentials. But you know, these tables show you. I just took some. These are available from the CSO. So you know, if you look at life expectancy at different ages, you can see the differentials. You know, at 65, you know, if you're a professional class, you have another 5 years at 65. Somebody better keep me time in mind here, just make sure I'm not. At 65, you know, if you're 65 in a professional class, you have 19 years, you know, whereas if you're on average, so if you're unskilled, you know, at 15, 5, 6, you have an extra 4 years. So where does that come from? Why does that exist? You know, and I think you've got to look at life course, life cycle, reproduction of health to know why that exists. Standardized death rates the same way. You know, like when I looked at this back in the end of the 1990s, you know, standardized death rates, we did it by cause of death as well. You know, cancers and heart disease were more equal killers. In other words, the differential was less than, for example, respiratory diseases, or suicides and accidents, and so on. So you even get differentials in the way of dying. You know, respiratory illness tends to be much higher differential than cancer or hearts. Just going to travel mortality differences there. You can see the difference relative to baseline of 100 with respect to these heart disease, respiratory illness, external cause, and so on. You know, 3-4 times differences in terms of death rate. Okay. So to try to think about this then, sort of production of health. Well, the relationship here is well known now, of course, but there's no single theory of social economic gradients. We know, for example, that health affects socioeconomic status as well. Sickness reduces earnings, for example, and so on. So there's all different sorts of causations as well. But we know increasingly, however, a couple of things. One, that life cycle matters. One, that, you know, parental resources, childhood health, have cumulative effects across the life cycle. Now, the reason I raise this is because even if you didn't have scarce resources, because we now have exceedingly scarce resources. I think we need to figure out how to prioritise if we want the impact on the production of health. And I think there's an increasing amount of evidence, you know, with scarce resources, you're going to have to, if you're interested in maximising health, yeah, looks like half my glasses, 2 minutes. Yeah. You're going to have to focus on where you want to invest. And I think there's an increasing amount of evidence that child inequalities are key over the lifetime. We also know from Grossman's model in 1972, you know, in terms of production of health, that education matters. Education is a really important variable in allowing people to make choices about health. Grossman had sort of the classical model of production of health, where people could choose in a sense their own level of health. But education matters also as a technology variable. You know, the more educated we are, the more we're able to make better use of education in sort of like a new piece of technology to improve our health. Just on the access to healthcare, just to make the point that, which goes back to what I said, I'm not minimising the role of access to healthcare, because power and money tend to seek out health improvements first, and then the rest of us tend to follow. So it is important that we have access, that there's a rapid diffusion of technologies, because what tends to happen is those who have money tend to find the best technologies first, and the quicker we get those technologies then out to people without money, it's really good as well. So that's why access is important, generally. Role of families, really think it's underplayed, and as I said, that's where we're working at the minute with people with dementia, the potential of caring communities, the potential to activate communities to be caring. You know, one of the things we're doing at the moment is to try to encourage people in catchment areas of 40,000 to 80,000 to be aware that people with dementia have certain rights as citizens to just engage naturally in community living. So therefore they should be facilitated, whether that's in shops or whether that's in sort of visibility in public spaces, to be supported within communities. But I think this is underplayed. And linking the health economy in society, I think, is another key ingredient to production of health. So in conclusion then, I think one of the things is that focusing on healthcare, we will miss all these issues. We will obviously begin to think about problems when they hit the hospitals or hit the technologies. So we'll be looking at spending money on ever-increasing technologies, i.e. we've doubled our expenditure on healthcare as a percentage of GDP in the last 10 years. Some of that's on technologies, that's on wages. So we can hire more and more expensive consultants, more and more expensive technologies to treat more and more people who are sick. And yet we know that that's not going to stop, because we know that health production is a function or relationship to the sort of socioeconomic gradient, the way we organise society, the way we organise work, the way we organise communities. And I think if we manage to break that cycle, as well as dealing with the access problem to healthcare, I think we have made major progress. So I think we need to just move away from clinically based health. You know, I think one of the things we need to think about is that health inequalities are critical and crucial to understanding the success and failure of the Irish healthcare system. You know, it's very rare that you get a discussion, for example, in popular media or popular culture. Nobody comes on the radio and talks about health inequalities, but people talk about people on trolleys. Having people on trolleys is not nice. You had to be on a trolley, or your parents had to be on a trolley, or your friend. It's not nice. But, you know, can I suggest that, you know, it's a lot, there's a lot worse things, and that is a lot worse things than actually dying being among them. And I think we need to get that message out, that certainly we're making decisions on who is living and dying right now on the basis of the way we organise sort of production, our health production system. I think we need to link health, economy and society, because I think that's going to, if we could manage to do that, I think it would transform the way we may think about health, and it might also allow us, even if we don't care about inequalities, I think it might allow us to have more investment to deal with inequalities, because in the interest of the economy, that more people are healthier and live longer. So what would I do? I'd prioritise access to medical technologies for sure, equal access, education, critical in terms of a technology variable, early childhood intervention and developing caring communities. Thankfully and hopefully the Department of Health say they're beginning to think more and more about this. We've had it before you know, in terms of policy documents over the years. They say they're now evolving towards a more community-based policy, a more health-oriented policy. So let's hope they move in that direction, because I think it will be hugely valuable in terms of maximizing health.
Thanks, Eamon. That's great. So, any questions at this point for?
We just have a small query about the point you made about families and communities being underemphasised in the health production model. I would suggest that where you have the word family, you use the word women. The vast majority of carers are women, not men and not families, they're women. And more than that, recently the changes to carers allowances and the challenges to supplementing the work that they do is actually decreasing. It's being threatened and challenged all the time. So a model that relies increasingly on the community, and in particular families and in particular women, is going to fail unless the actual gender difference is recognised, the vulnerability of those women in those kinds of situations, and the actual policy needs to support that model are recognised.
Yeah, absolutely agree. I've done work over the years looking at women caring for people with dementia. Women predominantly care. Women give up most. You know, absolutely true. In terms of, I would say there is a small older care, older men. There's a lot of older women in particular who care who have even more difficult, because they're at an age where they're asked to do things for their partners, spouses that are really difficult. So I absolutely agree. So my point on the sort of caring communities, I'm not using the caring communities as a kind of residual for picking up states' ability to sort of provide care, but I do think there is something to sort of mobilising communities to recognise and sanction illness and sanction difference, whether it be mental illness or disability. Or it's more in that context that I think about sort of caring communities than have it simply as an excuse for. But there's absolutely women care, and policy doesn't support it. For the last 25 years, I've been looking at this in terms of older people in particular. It's got both sides.
Thank you. Just speaking from my own perspective, I'd love to see much more in Ireland, in the Irish health system, much more emphasis on decentralisation. Just looking at paediatrics, I think the kind of the Leviathan landing in the middle of George and Dublin has been planned, as the answer to all paediatric problems. I think this was crazy myself. It's huge. It's got all the problems of a mega organisation. And if you look at the needs of tertiary care, a third of the size would do. And you could decentralise the rest. But I mean, there's huge pressure on centralisation, and the costs of that in terms of families, children, unemployment are very real. And if you look at Scandinavia, they're much better at having small units around the place, and the care is very organised in terms of what you can look after locally, and maybe you centralise and then decentralise again. So I think our system is totally lacking in imagination, in terms of decentralisation. And we were a thin population compared with Europe, and that's what we should be about.
Thank you very much for that. I'm not as convinced as you about the economics of health and community. It's not all bleak. It's not all bleak in the sense that we are living longer. That in itself, as you quite rightly pointed out, has consequences in terms of healthcare and how we're going to deal with that. And we put on top of that the kind of the schism we're going through in terms of our recent past in terms of economics and so on. And if you look at cyclical trends, for example, Herbert's work in America and so on, you see the consequences of economic fluctuations and pressures on things like unemployment and suicide and all the rest of it. Now the problem here is that people are living longer. We have those associated problems. But you know what? The whole issue of equity in healthcare is very much alive and well. And I don't kind of buy into the kind of, you know, the kind of more neoliberal argument that we need to transfer some of that responsibility to individuals, and particularly families, and in particular, not always mothers, but primarily mothers, as the manager of healthcare in the domestic setting. So I'm not entirely convinced by that. And I mean, let's face it, there are communities and groups in society, in Irish society and other societies as well, which fare really, really badly. I'm one of the authors of the Traveller Health Study, so I know very well the detail involved in how travellers have suffered over the course of the past 10, 15 years in the so-called Celtic Tiger period, and in particular the plight of traveller men. Absolutely atrocious. The position of women is more or less static, but men actually there's a marked increase in that. So there is something in terms of equity now. My question to you would be this: where do you prioritise things? Do you see a shake-up in terms of access to or distribution of monies, or do we need to look at the de-bureaucratisation of HSE? Is that where we should be looking to first, or is it in terms of family community responsibility and it's all put together and so on? Where would the central priority be?
So development, well, just going back to the prioritisation first in terms of, I mean, at the moment, if we look at spending, we're spending a lot on technologies. We're spending a lot on paying for sort of health service providers, healthcare service providers. So I think you've got to make decisions first of all about whether you think about health in a different way. And if you think about health in a different way, then you can think about allocation of resources to increase, for example, care benefits. You can think about making sure children's allowances, the argument for reducing family benefits, or the argument for reducing, of supporting young families and so on in a health-related way. So in other words, if you get into the business, if you look at the healthcare budget, then you've lost the argument, or you're behind already. So I think you've got to actually think about this first of all as well. What do we want to do here? I mean, if we had a Department of Health, it would include, if we had a real Department of Health, it would include spending to do with education, it would to do with housing. If we were to, what are we trying to maximise here? We're trying to maximise health, and therefore I think you've got to first of all treat that within the healthcare budget. Then I think if we had a proper primary healthcare system and a proper community care system, in the area I work in, I mean, so many people needn't end up in long-stay care, for example, if you had a proper community care system, a supportive community care system. Yeah.
If you start from the point of view, if you look at a family dealing with an elderly person with dementia, that family, and in particular, usually the woman in the family, is trained to do the work that a professional will do, if a professional could be available. In many instances, all of the physical work, the implementation of the medication, the OT, all of that, the family is trained to deal with and to implement. And yet we don't cost that activity as if it was being provided by at least a semi-professional person. Because they engage in all kinds of training of the family, and the model is, first and foremost, the family will take responsibility. And what I find upsetting is the idea that it's dressed up in a kind of, this is the appropriate way to provide this service, rather than saying, let's exactly cost it, let's use a model of costing the support that is now being foisted on the community and the family. Let's cost that in the same way we would cost other kinds of services provided professionally.
Yeah, I don't know that we did one on dementia, cost of living study in dementia, and so we costed family care, and we knew, so it came out that about 50% of the care, this is your generic care of people with dementia, is done by family carers. So if you take a cost of illness of dementia for Ireland, about 1.7 billion, about 750 million of that is to do with sort of family carers. So there are estimates there. You know, it's how it's relates to how you actually structure care. You know, matters.
So kind of, because I'm doing very well on the primary care teams, so I can sort of mediate between, I can, you know what you're saying about how you look at health, and I think by looking at the economic perspective, you have to respect that in the sense that even though the economic measures may not make you feel any better about the sort of healthcare that we deliver, but at the end of the day, like I've been looking at how little progress has been made implementing the strategy, and unless we can show economically that it's a sensible way to go forward, it doesn't seem like we're ever going to make any progress with it. So, although like the economic measures don't mean anything in terms of like the person who's ill, or like they're not really meaningful from a health care perspective, but from a change perspective, a health production perspective, I can appreciate how they're so important, because I just don't think so. I suppose I sort of support your kind of more grounded inclusion.
Yeah, I don't have. You know, I mean, I'm working economics, but I don't have a particular view.
Yeah, I mean, just to respond to that problem, I mean, why then are we still, you know, in the business of protection, of kind of employment protection for top GP surgeons and all the rest of it? Why don't we simply produce more doctors and put them out there? And you know, because the net result of that is that, you know, the status will decrease. You know, the pay scales will decrease and all the rest, just as it has happened with other areas. But we don't do that. We're not doing it. We're producing some more doctors, but we could be doing a lot more in that area. And you know, I mean, we're talking about economics, and impact economics.
Strong arguments for that.
They are being really productive, really provocative, and I'm sitting beside somebody from the nursing, but we are professionalising I'm not, so forgive me, I'm not a health sociologist, but it seems to me that we are doing a small amount of work in this area at the moment, but it seems we are professionalising the field, and in particular nursing, rightly so, but at the expense, often it seems, of the community. So the community are now taking up, for free, or pretty much for free, all of the responsibilities that would have been the health professions, and we're dressing it up as, oh, this is the best health care, this is the most humane, this is what the patient wants.
I just want to come back to that. I'm not quite sure that historically that's accurate, really, because actually, primarily, families did look after families. I mean, it's really only in the last 20, 30 years that you have actually had such an emphasis on a health system. Up until the 50s, 60s, even late 70s, you know, healthcare was primarily within the home. I mean, going into a hospital was the last place anyone ever wanted to do. It's the equivalent now of going into a nursing home. You have that stigma attached to it. So, and that really, you know what I mean, we kind of have this like idealized view that, you know, family care is something new and it's a product of our recent society. It isn't. It's historically the model that was in place.
There's also an interesting issue of body's health. I mean, in the sense that, you know, if you were to ask me when I was growing up in a rural area 45 years ago, was there anybody with Alzheimer's or dementia around and say, oh no, there wasn't. But now I look back and say, yeah, they were all over the place. I just didn't recognise them. You know, they were just my neighbours, actually. You know, but actually they just wandered around the place.
That's not an answer. No, but we did it 40 years ago. So why isn't it good enough to bring it back? We're not 40 years ago. We are now where we are.
No, but to be equally, I mean, I don't have but you could make a counter argument that says, well, actually, you know, the best place, if I could organise my own care, I would actually like to wander around Sawhill in Galway, actually, if I could. But I know I won't be late. I know that the first sign of my kids will have me somewhere, you know, in some institution where they visit me every, you know, quarter. You know, so it's a really interesting discussion about health.
Undoubtedly, there's a subtle shift in orientation here. And this is one, and it ties in with kind of wider neoliberal philosophy, I have to say, which Britain and America and various other countries have embarked on. And that's this shift of responsibility for health. From a service which we pay for, we pay a lot for, to this home-based social capital type service, health capital type service. That's all right. We all know the dynamic, that's fine. But let's pay half the tax, or let's pay the appropriate. These all have to be discussed in the mix.
Or let's ask the question: what happens when you actually go into these? I mean, if you were to ask me the question, what do we know? We know very little about what happens in long-stay care, for example, and we know very little what happens in families when older people are being cared for. We know equally little. We know equally little. Yeah, but we don't know anything about no. We notice this. We don't know anything about quality of life. No, nobody ever asks me if I'm being looked after by my, by my son or daughter, or by daughter or how's your quality of life? Is it good? Because the assumption is that if I'm being cared for at home, there's no need to ask that question. If I'm increasingly in a long-stay environment, or people are saying to me, we better go in and check that. Actually, we better set up a group called he could check it out. But nobody says, well, why don't you check out how he's doing at home, actually?
But we do know quite a bit about what the impact on families.
Oh, we do. I mean, we do know that, but
very, very poor.
Yeah, but as I grow older, I would like to know the impact on me.
Long-term implications of institutionalization. We better leave it there. We're over tonight. So thanks.
Okay, thanks.